Multiple choice question number 1.
A 26-year-old woman with a history of recurrent miscarriages is found to have positive lupus anticoagulant and anticardiolipin antibodies. She is currently 8 weeks pregnant. What is the best management to reduce pregnancy loss? A. Start low-dose aspirin alone. B. Begin low molecular weight heparin and low-dose aspirin. C. Prescribe corticosteroids throughout pregnancy. D. Advise expectant management without anticoagulation. E. Initiate warfarin therapy.
B is correct. In antiphospholipid antibody syndrome with recurrent pregnancy loss, combined treatment with low molecular weight heparin and low-dose aspirin improves pregnancy outcomes. Aspirin alone, A, is less effective. Prolonged corticosteroids, C, have risks without proven benefits. Warfarin, E, is contraindicated in pregnancy due to teratogenicity. Expectant management, D, carries high miscarriage risk.
Multiple choice question number 2.
A 30-year-old woman at 28 weeks gestation presents with severe pruritus, jaundice, and elevated serum bile acids. Liver enzymes are mildly elevated. Fetal monitoring is reassuring. What is the most appropriate management? A. Immediate induction of labor. B. Administration of ursodeoxycholic acid and close fetal surveillance. C. Start corticosteroids for fetal lung maturity. D. Initiate antiviral therapy. E. Expectant outpatient management without treatment.
B is correct. This clinical picture is consistent with intrahepatic cholestasis of pregnancy. Ursodeoxycholic acid relieves symptoms and may reduce fetal risks. Early delivery may be planned if bile acids rise or fetal compromise occurs. Induction, A, is premature unless indicated. Corticosteroids, C, are generally reserved for preterm delivery. Antivirals are not useful. Expectant outpatient management without treatment, E, risks fetal complications.
Multiple choice question number 3.
A 29-year-old woman with secondary infertility has regular menstrual cycles and normal hormone profile. Hysterosalpingography shows bilateral tubal occlusion. What is the most appropriate next step in management? A. In vitro fertilization, IVF. B. Tubal reconstructive surgery. C. Ovulation induction with clomiphene citrate. D. Expectant management. E. Hysteroscopy.
A is correct. Bilateral tubal occlusion prevents natural conception. IVF bypasses tubal pathology and offers the highest success. Tubal surgery, B, has limited success with increased risk of ectopic pregnancy. Ovulation induction, C, is ineffective without tubal patency. Expectant management, D, is unlikely to result in pregnancy. Hysteroscopy, E, evaluates intrauterine cavity, not tubal status.
Multiple choice question number 4.
A 24-year-old woman presents with primary amenorrhea, normal breast development, and scant pubic hair. Karyotype is 46XY. What is the likely diagnosis? A. Androgen and sensitivity syndrome. B. Turner syndrome. C. Mullerian agenesis. D. Gonadal dysgenesis. E. Hypogonadotropic hypogonadism.
A is correct. This patient has complete androgen insensitivity syndrome, characterized by female external phenotype despite XY karyotype, normal breast development due to peripheral conversion of androgens, and sparse pubic hair due to androgen receptor defects. Turner syndrome, B, is 45X. Mullerian agenesis, C, has normal pubic hair and karyotype 46XX. Gonadal dysgenesis, D, presents with streaked gonads and delayed secondary sexual characteristics. Hypogonadotropic hypogonadism, E, involves absent puberty.
Multiple choice question number 5.
A 31-year-old woman presents with cyclic pelvic pain, severe dysmenorrhea, and infertility.
MRI reveals endometrial tissue within the uterosacral ligaments and pouch of Douglas. What is the most appropriate initial management? A. Surgical excision of endometriotic lesions. B. Combined oral contraceptives and NSAIDs. C. GnRH agonist therapy. D. Hysterectomy with bilateral oophorectomy. E. IVF without prior treatment.
B is correct. First-line management of endometriosis is medical therapy, with hormonal suppression using combined oral contraceptives, along with NSAIDs for pain relief. Surgical excision A may be considered if symptoms persist or infertility is severe. GnRH agonists, C, are second line due to side effects. Hysterectomy, D, is a last resort. IVF, E, can be considered later for infertility.